All right, thanks everyone. Hi, I am Dr. Michelle Jones, and I am so excited to be here chatting with you guys today. I know Jennifer is as well. You'll hear from her in just a minute. Um, just to give you guys sort of a quick overview, this is a 6-week series. I believe this is on the website as well, but just sort of a heads up for everyone who's on today. We have several different topics that we're going to be covering over the next few weeks, so take a look at this. If there's anything that really stands out as interesting or relevant to you, please plan on attending those weeks. Come to as many as you'd like. We'd be happy to have you. But today we're going to start off just doing sort of a basic overview of ARFID, making sure that everyone is familiar. We're kind of all on the same term or on the same page in terms of terminology, understanding of what ARFID is, dive a little bit deeper into some of the different nuances and subtypes of ARFID. So Jennifer and I are going to be covering some of that information today. So all of you guys are here because you have some sort of connection to an individual in your life who has avoidant restrictive food intake disorder, commonly called ARFID. And this is a relatively new diagnosis. So it was first a formal diagnosis in 2013, so a little over 10 years ago, which in the world of psychiatry is really very new. And I think probably most, if not all of you, have had experiences of encountering providers or professionals that are just not familiar with it. I know I've had experiences of speaking with non-eating disorder professionals who say, ARFID, what's that? Or what's AFRID? I've never heard of this before. And so I think it's important for us to be really spreading the word and helping people understand what this diagnosis is, because it does impact a large portion of our eating disorder population and more people than I think a lot of us really even realize. So prior to 2013, people with ARFID-like symptoms were given a different diagnosis. There were several options available at that time, but none of them really adequately captured that experience. So having the ARFID diagnosis was really a big landmark in the eating disorder world, and helping people have this sort of term that appropriately and adequately describes what they're going through. And that really helped us start to develop some treatment interventions and a better understanding of what people with this disorder are living with. So when we talk about ARFID, we're referring to a restrictive eating pattern that persists over time and results in one of the following. So you can have one or more, you can have all four of these. The first one being significant weight loss, and that would be for an older adolescent or an adult, or this in younger children could be a failure to achieve expected weight gain, or they have kind of faltering growth. So kiddos that are sort of chronically low body weight in a way that we wouldn't expect given genetics or given how they were at a younger age, falling off growth curves and things like that, or just a significant amount of weight loss that happens later on in life or even earlier in life as well. So that's one of the more common symptoms that we'll see pop up, especially at higher levels of care, but it's definitely not a requirement to receive this diagnosis. They might also have significant nutritional deficiency. So this is a little bit different than just insufficiency. This is a true nutritional deficiency. So something like scurvy that we wouldn't necessarily see in modern society. Again, not super common in ARFID, but that would be an example of a type of nutritional deficiency that one might see. People with ARFID could be completely dependent on enteral feeding, so things like NG tubes, PEG tubes, some kind of feed that's done through a tube entering their body, or oral nutritional supplements, so Boost or Ensure or something along those lines, that really is comprising 50% or more of their nutritional intake. So if that's the case, then that may be reflective of them having that ARFID diagnosis. The last one is one that can exist completely on its own that I think sometimes gets a little bit glossed over, and that's this marked interference with psychosocial functioning. So people who have ARFID, maybe they're a normal body weight, maybe they, are kind of meeting sort of basic nutritional needs, but they really struggle to go to a party at a friend's house. Like maybe, let's say they're a teenager in high school and they really can't attend functions with their friends or attend school functions because there just is never anything available that they're able to eat there. Maybe they have never eaten at a restaurant or won't be able to eat at a restaurant because they just can't order anything off the menu, and that's causing distress for them. It's an adult who maybe wants to enter the dating world, but they really don't feel equipped to do that because they aren't able to engage in some of those sort of normative social behaviors of taking someone out to eat on a date or going to meet people, in functions that involve food in some way. So this eating or feeding disturbance can take a few different forms, and we'll deep dive into this a little bit more today and in the coming weeks. But this could look like maybe someone just isn't as interested in eating food. Maybe they have a low appetite. often people think about ARFID as sort of this picky eating disorder. And yes, that is one way that it can present, although it's much more than that. And we'll get into that again in a little bit. Or it could be something kind of more along the lines of really fearing a potential negative outcome of eating. So worrying that if they eat a certain amount of food or certain types of foods, that will result in them vomiting or choking or having GI pain or something along those lines. So it can take one of those forms, or it can take multiple of those forms. So a few things for us to note. Those are kind of the basic diagnostic criteria for ARFID. There's a few sort of rule outs that I want to make sure that everybody is aware of as well. So there is some, confusion sometimes between ARFID and other eating disorders. Most commonly, people sometimes get a little mixed up between ARFID and anorexia. If somebody currently meets criteria for anorexia nervosa or bulimia nervosa or any other eating disorder, binge eating disorder, or something along those lines, that would mean that that person cannot receive an ARFID diagnosis. You cannot have multiple eating disorder diagnoses at one time. They may still have ARFID symptoms that meet criteria, but formally they would have a different diagnosis. We also want to make sure that we're not diagnosing people with ARFID if they are restricting their eating due to a cultural practice. Maybe they're fasting for religious purposes or restricting certain types of food because of religious beliefs, or within their culture, they don't eat certain foods, or there's sort of rules around eating certain types of foods, or if they're not eating enough or eating certain types of foods because of limited resources. Maybe they are low income and don't have the ability to get sufficient food. They can't afford to buy enough food and don't have access to food banks or something along those lines. So we want to make sure that we're being thoughtful about that when we're going through the diagnostic process. One of the big differences between ARFID and other eating disorders, particularly anorexia, is this lack of body weight or shape disturbance. That's really the most notable difference when you're just kind of glancing at somebody right away, is if that disturbance in body weight or shape is not present, then they really can't have some of those other diagnoses like anorexia or bulimia. And so that's when we're really starting to look more towards ARFID. That being said, people with ARFID absolutely can still have body image concerns and have some distress about their body image. Sometimes this looks like maybe they're distressed about being too thin. Maybe they wish that they weighed more, but their eating disorder is making it difficult to achieve that weight. Sometimes it looks more classically like anorexia in the sense that maybe they're worried about having a larger body size, or they are worried that they might become fat or gain weight. The difference being that they're restrictive eating. People with ARFID with restrictive eating are not restricting their eating because they're trying to prevent weight gain or they're trying to prevent becoming fat. Their restrictive eating is driven by something else, and their body image concerns are more within kind of a normative range. Most adult people, especially women, girls and women over, past puberty, are going to have some degree of body image distress or distortions. And it's really how much is that interfering. If it's not interfering with their functioning, it's not a reason for them to be restricting their eating, that would mean that they could have an ARFID diagnosis. So I always like to clear that up because that's a really common misconception. You can have body image concerns, but that's definitely not going to be a major feature of someone with ARFID and not something driving the restrictive eating. I want to make sure that everyone is aware too that you can have ARFID with another medical condition, but if another medical condition or psychiatric diagnosis explains the restrictive eating, then that would mean it's not ARFID. But you can have comorbid medical conditions along with ARFID as long as the eating problem, the ARFID requires some kind of independent intervention outside of just, medical treatments. So what is ARFID not? We covered some of this a little bit already, but ARFID is not just picky eating. So the term picky eating implies an ability to tolerate the foods that an individual is eating, but they're just not willing to. Like somebody who, if you think about little kids who are picky eaters, like, could they really eat those peas and they just don't want to? Yeah, that would be more like normative picky eating. It often comes with judgment to that term picky eating. So I don't really love that in the context of ARFID. People who appear to be picky eaters but actually have ARFID will have such strong disgust responses that they might gag or actually vomit from even smelling or interacting with the food. And then this disgust response is present for a large number of foods. So people who have this particular presentation of ARFID, it's a pretty extreme response in most cases, and it really is just so difficult for them to tolerate the sensory properties of food. There's also other ways that ARFID presents outside of this kind of picky eating like presentation, where they're really sensitive to the sensory properties of food. Like I said earlier, it could look like they just have really chronically low appetite to the point that they forget to eat sometimes, or eating just is not enjoyable, and so they're not going to go towards that. Or concerns about a negative consequence to eating, like choking or vomiting. And again, can be a combination of one or more of those types of presentations. So it's really more than just picky eating. A lot of times people think, and I'll hear this from patients a lot when they come into treatment, like, oh, I just have ARFID. And it sort of has this, sort of reputation of being a lesser eating disorder. And really, from a medical, nutritional, and psychological perspective, ARFID is just as severe as other eating disorders. When we look at the research on body weight of people who have ARFID when they are at a low body weight, it's comparable to people who are at a low body weight due to anorexia or other eating disorders. So we see the same kinds of medical complications. I know Jennifer's going to talk about this later on. We really know that ARFID is just as severe and just as impactful as any other eating disorder out there. ARFID's not just a behavioral disorder either. So our current understanding is that ARFID, like other eating disorders, has a primarily biological basis. So things like genetics and temperament are really driving the restrictive eating behaviors. And it's not the result of people actively choosing to engage in restrictive eating or avoidance behaviors. It's really driven by maybe they have a very anxious temperament, they have a traumatic experience with food, and then it feels impossible for them to not avoid some of those foods because it's just so scary to think about what could happen. It's not this active choice of, I've just decided I want it. I'm so afraid of this one thing I'm going to stop eating, or I've just decided I don't want to eat vegetables anymore or protein foods anymore. It really is driven by kind of their biological makeup in terms of how they experience anxiety, how they experience disgust, sort of what their brains are sort of geared towards in terms of experiencing appetite and things like that as well. And then the last thing, and I really hope, because all of you on this call are caregivers, I really hope that y'all hear this loud and clear. There is no evidence to support that ARFID is caused by parents or caregivers. There's actually a lot of evidence that contradicts that and says that parents and caregivers are incredibly important and really pretty crucial in helping people with ARFID in their recovery process. And so it's so exciting that you guys are all on here to hear this, because I think you're here because you care about your loved ones and you are going to become an even more impactful part of their lives and part of their recovery by learning about ARFID and learning how to support them. A few comments on ARFID versus other eating disorders. Again, because this is such a relatively new diagnosis, we want to make sure that we're distinguishing it from other eating disorders that might be more familiar to people out there. So a few different distinguishing factors between ARFID and other eating disorders. So all of this is based off of research comparing ARFID with anorexia and bulimia. So ARFID does tend to present more commonly in younger kids. We see it across the lifespan. I've met people in their 50s and 60s with ARFID before, but we'll see this sometimes in kids as young as 6, 7, 8 years old. We'll see signs of it even prior to that. So compared to other eating disorders, it's more common to see people present with ARFID at a younger age, whereas anorexia and bulimia, it's pretty uncommon to see that prior to the onset of puberty. So we're going to see that more frequently in older adolescents and young adults, going into the middle age and older adulthood as well, but most commonly in older adolescents and young adults. ARFID is also equally common between males and females. It's a pretty even 50-50 split for the most part, whereas other eating disorder diagnoses do tend to be a little bit more common in people assigned female at birth compared to people assigned male at birth. ARFID can, as I said, can begin as early as infancy or early childhood. Often people with kind of the more long-standing presentations of ARFID, you'll hear from their parents or caregivers when they're babies, like they were so difficult to feed as infants, they really struggled to put weight on. They were so picky, it was really difficult to transition from like bottles or breast milk into solid foods when they were older babies. Whereas anorexia and bulimia, often you see no signs of it until they're entering like preteen years or later. We've kind of talked about shape and weight concerns already. When we look at preferred foods, this is often a really easy kind of rule of thumb when we're looking at people who have ARFID. You're not going to see many people with anorexia or bulimia whose preferred foods are these really energy dense, high fat, high carb, low protein diets. So you're not going to find a lot of people with anorexia whose favorite food is pizza, whose favorite food is chocolate cake. You're going to see that a lot more commonly in ARFID. So whereas people with anorexia and bulimia, more body image driven eating disorders, tend to have the fear foods are the ones that people with ARFID are more likely to prefer. And then again, if a patient has ARFID or an individual has ARFID and they are underweight, they're likely to have chronically been at a low body weight. It's not something where it's as common to see this sort of acute weight loss, although it absolutely can happen. With anorexia and bulimia, it is much more common to see an acute period of weight loss to achieve that underweight status, being previously at an above, an overweight status or a normal weight status, and then moving to an underweight status if they are underweight at the time that we're making that diagnosis. So I'm going to turn it over to Jennifer. She's going to talk to you. Thanks.
So we're going to switch over and talk a little bit about the prevalence of ARFID. What we have seen at ERC over the last several years is that the number of patients that we treat that have ARFID is on the rise. So I'll start on the right-hand side of this slide. In 2001, at all of our ERC locations across the country, we had a total of 160 patients admit to one of our facilities with ARFID. Then in 2022, that number close to doubled because it went from 160 to 217 total patients. Not quite double, but getting up there. And then we even saw a jump again in 2023 to a total of 251 patients. So the prevalence of ARFID is increasing. Now, research is just coming into existence about ARFID, so it's been hard to really judge appropriately what the prevalence of ARFID has been in the past. Data does suggest that ARFID may be just as common as the better known eating disorders such as anorexia nervosa and bulimia nervosa, but more research will be helpful to make sure that that is accurate. And ARFID is diagnosed in both males and females, but it does appear, at least for now, to be a little more common in males. And then those with ARFID tend to be a bit younger upon diagnosis than those with other eating disorders. But just like Dr. Jones shared, we sometimes treat people with ARFID that don't develop ARFID until they're an adult, sometimes in their 50s and 60s. So it's not just solely diagnosed at a younger age. Youth with ARFID are more likely to either be underweight or overweight, so either somewhat malnourished or maybe potentially overweight if their diet is really focused pretty much solely on those highly palatable foods, because those are easy to consume more of than foods like fruits and vegetables. And right now, from what we know, ARFID could represent about 20% of eating disorders in treatment settings. So not just ERC, but any higher level of care that treats eating disorders. Less is known about the occurrence of ARFID with different racial and ethnic minority groups, but it has been reported in multiple Western and Eastern countries. So it's not just exclusive to the United States by any means. You want to go to the next slide? So what causes ARFID? Just like with the prevalent, causes of ARFID are unknown. More research needs to be done. However, this is what we do know. Those with ARFID do score lower on measures of eating disorder pathology. Their bias towards dieting is lower than people with anorexia nervosa, and it does not differ from healthy controls. People with ARFID can be just as low weight as those with anorexia nervosa, but weight is chronically low versus acute weight loss. So for example, what that means is, like, if we look at a growth chart, young patients with ARFID tend to fall on those lower percentiles, whereas maybe someone with anorexia nervosa may fall more towards the 50th percentile historically, but then there's this rapid drop from, like, let's just use it as an example, age 13 to age 14. But people with ARFID tend to be, in general, in smaller bodies and just trend lower on the growth curves, though not always. The medical comorbidity is similar to that of anorexia nervosa. That is why Dr. Jones, in part, was sharing, like, ARFID is not a a lesser eating disorder. It's not less severe. It can be just severe, just as severe as any other eating disorder, because the medical complications that come with it can be just as severe as the other eating disorders. Rates of anxiety and depression in ARFID are also similar to folks who have anorexia or bulimia. Autism, ADHD, and learning disorders may be a bit more common in ARFID than other eating disorders. We do see a lot of sensory processing disorders co-occur with ARFID, though not always. Or if you've heard the term neurodivergence, we do see a lot of neurodivergent traits, oftentimes, though not always, with our patient population who has ARFID. ARFID is less egocentric than anorexia nervosa. That means someone with ARFID is less ambivalent about letting go of the eating disorder. Now, don't get me wrong, there's still a ton of fear in letting that eating disorder go. But for example, someone with ARFID would say, okay, you're telling me I need to gain some weight. I'm willing to, but I just can't seem to eat enough to do that. Someone with anorexia nervosa would say, I don't need to gain weight. I'm fine. And really not try to avoid the problem that is being presented to them. And then youth with ARFID often lack recognition that eating disorder is problematic. So as someone gets younger, just their brain isn't fully developed. So there's less internal motivation to change, but we still have ways that we can help anyone with that motivation to try to take one step at a time towards recovery. And Michelle, I'm going to pass it back over to you.
Thanks. So we're going to spend a few minutes chatting about subtypes. We're going to deep dive into each of these over the next few weeks. So we're just going to be sort of a surface level overview for the most part. But I do want to talk specifically about the three primary subtypes that we are recognized within the field, research and clinical field, looking at ARFID and kind of what's most widely accepted. So there's three primary subtypes, and Jennifer will talk about a couple that are sort of secondary to that. The first one is sensory sensitivity, which is avoiding foods based on sensory properties, primarily taste and texture, but it can be other things like color and temperature or smell, any other sensory characteristics of food. Lack of interest in eating or low appetite sometimes gets thrown in there, but I usually refer to it as lack of interest in eating. Subtype is people who just kind of chronically have poor appetite, low appetite. They're not getting those same hunger cues from their brain that those of us who are normative eaters would get, or they have a low reward response to eating. So they really just don't derive pleasure from eating the way that a normative eater would really look forward to eating, plan celebrations around eating. You know, if you're sort of hungry during your work day or your school day and you're thinking, oh man, what's for lunch today? I'm really excited to find out. Or, oh man, I'm looking forward to dinner. I'm going out to eat with my friends. Let's get excited about the restaurant, maybe check on the menu and see what we're going to eat. People with this subtype are probably never going to have that experience and actually kind of have that experience of almost like eating sawdust all the time, and just nothing is enjoyable about it, or very few things are enjoyable about it. The third subtype is fear of aversive consequences. So this is a subtype that presents typically following a traumatic or perceived traumatic event. Most commonly it's with vomiting, but often can be choking, allergic reactions, pain, or other aversive GI experiences. So it's this idea that if I've had this traumatic event or this challenging sort of fear-inducing event, and from that point forward, this fear develops that if I eat certain types of food or certain amounts of food, then that negative consequence could happen or will happen. So then the restrictive eating sort of develops in response to that fear. So the numbers that I have on here are the percentage of people with an ARFID diagnosis who have that subtype. So you can see this as an overlapping Venn diagram, because you can have one of these subtypes, two of these subtypes, or all three. The most common presentation actually that we'll see is sensory sensitivity paired with that fear of aversive consequences. And actually, I think what we tend to see most commonly at higher levels of care is the fear of aversive consequences subtype, because that does tend to have more of an acute presentation where people have this traumatic experience and then they lose a bunch of weight or really become malnourished in some way, shape, or form. So we tend to see those people with that subtype more frequently than others at these higher levels of care that Jennifer and I work at. And if we look at people kind of in the broader spectrum, we're going to see a pretty wide variety. There's also pretty significant overlap between sensory sensitivity and this lack of interest subtype. So what are all of these subtypes? So as I said earlier, the sensory sensitivity subtype is avoiding foods based on the sensory properties of food. And most commonly, this is taste and texture, but can be other things. We had a patient not a super long time ago who would avoid foods that were not neutral colored. And especially she really had a hard time with red foods. So there are a lot of exposures built around that. So we'll see all different ways that people have sensitivity to the sensory properties of food. With this subtype, people tend to have a reluctance to try novel foods or new foods. Were you going to ask a question, Beth Ann? Oh, sorry. I thought I heard you. They typically exhibit a strong disgust response to new food. So this is the big emotion that's a piece of it. You'll hear a lot about anxiety with eating disorders. And yes, there is anxiety when it comes to subtype, but really the disgust is what we're going to kind of run into trouble with. Usually people with a subtype are going to eat, and if we divide food into major food categories, so fruits, vegetables, proteins, dairy, or grains, in at least one of those, you're going to eat fewer than 2 foods. And often it's more than one. We're not commonly diagnosing people with ARFID just because they don't eat any vegetables. We might diagnose them with ARFID if they're not eating any fruits or vegetables, or especially if they're really limited in protein sources or grain sources or something along those lines, something that's really going to have a major impact on their functioning or on their physical health or weight or something like that. Often people with a subtype have lifelong difficulties with feeding or eating. I work a lot with kids and I'll hear from parents like, yeah, this was really difficult. Like their entire life from the day they were born, feeding was really, really challenging. And accepting new foods has often been difficult since infancy, or certainly like around age 2 or 3 when the taste buds are changing a little bit, entering into those toddler years where the behavioral response might be a little bit different around food as well. For the parents on the call, if there's often challenges around introducing new foods for all kids, but kids with ARFID with a sensory sensitivity subtype just have really significant challenges. People with this subtype may not recognize that their eating patterns are just problematic, so it can be helpful, especially for younger kids who might have a lower ability to have insight into this. It's helpful to get some information from parents or siblings or grandparents or other people that interact with them frequently. And I think we also just have to kind of be aware that sometimes other people might look at someone and judge their eating as limited, and say, oh, you have ARFID, you don't eat any vegetables, or you only eat 2 vegetables. And yeah, maybe technically, but if it's not interfering with their life, we have to make sure that we're really being thoughtful about that. So people who truly have ARFID and truly have this sensory sensitivity subtype are going to be pretty restrictive with their eating. And that's often going to interfere with their normal sort of social functioning, psychological functioning as well. The lack of interest in eating subtype, as I've described previously, really presents with a couple of different things, and sometimes you have all of them, but it's just this kind of like eating just is not something that you enjoy doing. Maybe because you have low appetite all the time. You're rarely feeling hungry. If ever feeling hungry, you have to force yourself to eat. You might forget to eat or become easily distracted from eating because that hunger cue just isn't very loud in your head. Because of this, people tend to eat less in general, and so then they start to feel full prematurely. They tend to feel less hungry and more full. And they also will have this low reward response to eating. So I always give this example of, if you've ever had COVID or some kind of illness where you lose your sense of taste and smell, and then everything just kind of tastes like sawdust, like nothing tastes good or like anything at all. And it kind of takes the enjoyment out of eating. People who have this subtype experience this pretty much all the time. And so eating sort of becomes a chore and is not something they look forward to. This is another subtype that tends to be kind of a lifelong presentation. It's not one that tends to start acutely unless there's been some sort of a medical condition that prompts it. The last one is this fear of aversive consequences. So again, people who are avoiding eating due to worry about something bad happening during or after eating outside of shape and weight concerns. So most commonly vomiting fears or emetophobia, we might call it. Also choking, GI discomfort, allergic reactions, sort of general contamination. And so when people they often will have this sort of traumatic experience. Maybe they have a really terrible stomach bug, or they actually have a choking or near choking incident. And then following that, they start to engage in these safety behaviors used to prevent the feared outcome from happening. So avoiding eating certain foods that they worry might make them vomit or choke or something like that. They might avoid eating larger amounts of food. They might stop eating altogether. They might stop eating in certain situations. And so typically this starts to build and build and build. Unlike other subtypes, this is not one that is sort of a long-standing. It typically has an acute onset. There is that sort of traumatic event that prompts us to start. That tends to be more common in younger individuals, more likely to present in females, and tends to involve heavier dietary restriction. And so often we'll see lower body weight associated with the subtype 2. Okay, I'm going to hand it over to Jennifer to talk about the other two.
So we have two other subtypes that we try to categorize different ARFID presentations in. I will say, compared to the three that Dr. Jones just talked about, these two are not what are considered clinical subtypes, meaning you're not going to find them in the DSM-5, where all of the diagnoses for mental health disorders are found. But these are things that we see often. So we have a category to put them in. So one is that mixed subtype that Dr. Jones already spoke about, where you see maybe that fear of negative consequences and then that sensory sensitivity connected. One may come before the other, or they both may present together. So lots of different mixed subtypes of ARFID can be present or can evolve over time. And then we have what we call ARFID plus. And this is where individuals with ARFID also start to develop features of anorexia nervosa. And those features of anorexia nervosa may come at kind of the onset of the ARFID, or they may come later. So these are folks who have ARFID and concerns about body weight and size. Maybe there's a fear of weight gain, which is not typical with like true pure ARFID, or there's a negativity about becoming too fat, or they're dealing with negative body images, or there's a preference for less calorically dense food. So we're seeing some of those restrictive types of behaviors that are most common with anorexia nervosa in patients who also meet the criteria for ARFID. We'll go to the next slide. So when someone has the diagnosis of ARFID, it is so important that they receive help from a multidisciplinary team. And what we mean by that is they need a psychiatrist to help with that medical management. Or sometimes the PCP, your primary care physician, may play that role, just depending on age of the person with ARFID and the mental severity. Sometimes it's helpful, though, to have both medical disciplines on the treatment team. Then there's the therapist who does not only individual therapy to help them work through the mental aspects of ARFID, all of those thoughts and behaviors and urges, but then also helps provide family therapy as well, because no one lives in isolation, and ARFID affects the entire family and how you operate. So it's really important to have a therapist as well. And then a dietitian who can help with the malnutrition, help repair that, help them become better nourished, help come up with ideas to help them expand their variety over time, things like that. Then you may benefit from having an occupational or speech therapist on the treatment team, again, just depending on the presentation, and possibly as well, or a GI specialist. If there is some medical complications going on with the digestive tract, the GI specialist will be able to monitor for that. And something I always tell families and caregivers is that family members and caregivers are just as important members of the treatment team as any of the clinicians. You have an expertise in your loved one that we will never have. And we need we need you to bring that expertise to the table, because you're vital in this recovery process. So we view families and any loved ones associated with helping someone in recovery be a very active participant, just like you're being today in this group.
Yeah, absolutely. And I'm glad that Jennifer, you kind of spoke to the impact that ARFID has on the entire family, not just the individual with a diagnosis, but also the people in their lives as well, both immediate family, close friends, or extended family. There's so many different challenges that can come up, and given that this is one of the pieces that could be the only piece that gets someone an ARFID diagnosis, I think it's important to really look at the impact that ARFID can have on someone's psychosocial functioning. So, social life, we've talked a little bit about, like, if somebody is invited to a birthday party but won't attend because they're concerned that they won't be able to eat the food that's offered, and that's sort of the only time of day that they're able to eat food. For younger kids, like especially elementary, middle school age kids, or even into high school, finding foods that they can eat at lunch is often very challenging. Maybe if there aren't like packed foods that they feel comfortable eating, there's nothing in the cafeteria that they feel comfortable eating. Maybe they're so overwhelmed by the smells and the sounds and the look of the food that their friends have at the table that can be overwhelming. We think about things like mood and energy levels. That's really negatively affected by not consuming adequate nutrition. So if you're not eating enough carbohydrates or protein, your body's not going to have the energy to do the things that it needs to do. If you're not eating enough in general, it's not going to have the energy to do the things that it needs to do throughout your whole day. Maybe it's hard to hold down a job. Maybe it's hard to focus on school. Learning might be negatively impacted. We know that nutrition and mood can be closely tied. And so if you're not getting enough nutrition, you might tend to be more depressed or more anxious. Family meal times often with someone who has ARFID is just really challenging and stressful for everyone involved. Parents can get really anxious about feeding their kids. I mean, of course, parents are anxious about a lot of things in the parenting process, but worrying about food and eating is something that is present from day one. I mean, you're taking your baby to the pediatrician and getting weighed, they're charting growth, and then that doesn't stop over the course of a child's lifetime. And then parents also, as the child gets older, start to worry about how is this impacting friendships? How is this impacting their functioning in school or their ability to do sports or other extracurricular activities? The kids around the child with ARFID might also be impacted by that. I know I've spoken with parents or kids who have a sibling with ARFID, and it's like eating is always stressful, dinner time's always stressful. My mom's having to make 3 different meal options every single day, or my sibling is really getting catered to and my meal preferences are being forgotten. Then they may have behavior that stems from that is unhelpful in the family relationship. The relationship that a child with ARFID has, their parents can be strained by the ARFID diagnosis. If there's kind of always this battle around food, the parents are feeling like they're the food police all the time, or they're constantly having to push their kid, or they're constantly having to reassure their child about, you're not going to throw up if you eat this, or you're not going to choke because you ate a bite of a chicken nugget. There's kind of all different things that can kind of come into play here that just generally creates a ton of stress in the family system. Parents might really doubt their ability to feed their child. They might sort of doubt their ability to be an effective parent. It can impact family finances as well. If your child's very selective and you have to kind of go towards those few foods that they can eat. I know I had a patient one time who one of the 5 foods that he ate were pine nuts. Well, pine nuts are not especially cheap. And so if you're having to really stock up on pine nuts all the time, that can impact your financial situation, as well as having to have appointments with providers or, seeking medical workups and diagnoses in different areas. I think most of you guys probably know, like, ARFID is not often, you're not diagnosed with ARFID usually in the very first visit with a provider of some kind, because it is so difficult to find a provider who's familiar. And so then we think about like family vacations. If you're very restrictive in your eating, it's difficult to go on a trip somewhere else. And I know I've talked to several people who have gone on school trips or gone on family vacations and eaten essentially nothing for like a whole week because there just wasn't anything available to them. So it really limits your ability to be able to socialize in a normative way, to attend events in a normative way, to go on vacations, to engage in school or engage in work, to just sort of function throughout your day. And so I always want to underscore the really significant impact that this diagnosis can have on someone's psychological functioning and social functioning. So that's one of the things that therapists are really focusing on in treating ARFID. We're really looking at, well, first of all, I want to say therapists and dietitians work incredibly closely together, more so I would say than almost any other diagnosis. There's so much joint work done on exposures and planning around exposures and identifying foods, identifying goals. It's really a very collaborative process, especially at higher levels of care. It's something that we're constantly doing. Jennifer and I have shared ARFID patients before, and we're just like in each other's offices all the time talking about that. Um, and so when we're looking at how therapists are working on the multidisciplinary team, we're really focusing on those thoughts and feelings and behaviors related to the fear, the disgust, or the emotions surrounding eating and the behavior surrounding eating. We're looking at factors in the family and the environment that are serving to maintain the ARFID symptoms or preventing progress towards resolving those or reducing those. Looking at how the eating disorder impacts psychosocial functioning and trying to figure out how we can improve psychosocial functioning by addressing the eating or minimizing the impact of the eating on the psychosocial functioning. Looking at avoidance behaviors, where are you avoiding the things that feel hard and how can we help you work against that urge to avoid? Building in that outside motivation, because sometimes it's really hard, as we've already talked about, it's really hard to know, like fully have insight and recognize how impactful, negatively impactful these eating disorder behaviors can be, or maybe you want to get better, but it feels really hard, you can't do it on your own. So we're going to help support building those outside motivators into the plan. And then, as I said, we're working very closely with the dietitian to develop that individualized plan for exposures for feared foods and for feared situations. And we're conducting a lot of those exposures in fun and creative ways, not necessarily fun, but creative ways, and really individually targeted ways to help resolve some of the ARFID symptoms.
Dr. Jones and Beth Ann, I'm curious, we've got about 13 minutes left. Should we pause here and pick up we only have a few more slides, but we could talk about the medical and nutritional impacts of ARFID next week, along with the sensory challenges, because there's so many great questions that I'm seeing come through in the chat.
I agree, Jennifer. I think it would be great if we hit the pause button here and and then start to tackle some of these great questions.